Today, we are going to discuss an introduction to psychopharmacology. We're going to focus on the different principles, but the specifics of each drugs will be discussed according to the management of each disorders as you go along and have your lectures with the rest of the faculties. Okay, so this is just an overview for you to be oriented. So at the end of this 1 hour lecture, you as the medical student would be able to understand the definition and the scope of psychopharmacology, to enumerate the class of medications used in psychopharmacology, and to discuss the impact of these medications on mental health, treatment, and neuroscience. You will be also able to discuss the different patient factors considered in making informed decisions when using medicines, and explain how drugs interact with the neurotransmitter systems involved in the management of psychiatric disorders. And lastly, to discuss ethical principles and considerations when prescribing um, psychotropic medications. So this is the overview of the topics that we're going to discuss today. So first, let's try to define psychopharmacology. So it's the study of the influence of drugs on mental, emotional, and behavioral processes. So it's concerned primarily with the mode of action of various substances that affect different areas of the brain and nervous system, including drugs of abuse. So this is taken from the American Psychological Association definition. But basically, psychopharmacology just deals with how drugs, including those that are prescribed medications and recreational substances, affect our brain and our behavior and the rest of our mental processes. So it's actually a multidisciplinary field. So it combines elements of neuroscience, pharmacology, psychology, and psychiatry. And we try to understand in this field the interactions between the drugs and the brain. So when we say psychotropic medications, it just simply refers to those medications used to treat psychiatric disorders. So why do we need to study psychopharmacology? Because this is one of the modes of treatment in psychiatry. So it's primarily used for symptom management or control of psychiatric symptoms. Of course, to improve the functionality of the patient, which is usually the goal of treatment, to prevent relapse or recurrence of psychiatric symptoms, and to address emergency situation or to provide emergency interventions. So what then are the classifications of psychotropic drugs? So the classification of psychopharmacologic agents can be described in terms of their major clinical application, their structure, their mechanism of actions, mechanisms of action, their history, and their uniqueness. So for example, when it comes to classification according to major clinical application, you might hear the term antipsychotics, which means that their clinical indication is to address psychosis. We can hear the word antidepressants. Basically, from the name itself, it can be used to target depressive symptoms. Mood stabilizers are there to target or to treat mood dysregulation. Anxiolytics to help control anxiety, and hypnotics if you want, for example, those who want to be um, sedated. Okay? In terms of structure, some psychotropic agents can be described as, for example, tricyclic. Tricyclic antidepressants are primarily used in the treatment of depression and anxiety. So you can hear that those terms, but basically in psychiatry, according to structure, only tricyclic antidepressants are more common used. Okay? For mechanism of action, you can hear the word, for example, SSRIs, which refers to serotonin selective reuptake inhibitors. From the name itself, so you can already infer how the medication is targeting the receptors in the brain or the reuptake of the neurotransmitters in the brain. So, for example, if you hear the word SNRI, it means it deals with the reuptake of serotonin and norepinephrine because SNRI means serotonin and norepinephrine reuptake inhibitor. For MAOI or MAOI, it means monoamine oxidase inhibitor. So it means it inhibits the effect of the monoamine oxidase. We can also be familiar with the word dopamine receptor antagonists, which just refers primarily to antipsychotics. or for serotonin dopamine antagonists, which also refers to the second generation antipsychotics or the newer antipsychotics. Okay, so in terms of history, antipsychotics have been classified according to how they were discovered first. So for those older antipsychotics, we call them first generation antipsychotics, and most of them, or actually all of them, are known to have more dopamine receptor antagonism compared to the second generation or the newer antipsychotics, which has additional serotonin antagonism. So there are benefits of that, of course, since first generation antipsychotics are known to have more side effects compared to the second generation. So just be familiar with the terms, okay? In terms of uniqueness, you can hear typical and atypical psychotropic medications. For example, in antipsychotics, when we say typical, it means it refers to the first generation antipsychotic. But if it's atypical, it means it's more of the second generation antipsychotics. So before we go to the other principles, though, you have to know how psychotropics medication work in facilitating or in affecting neurotransmission systems. So most of the mechanisms of actions of your psychopharmacological agent will target the neurotransmission, particularly the chemical neurotransmission. So that's why I wanted to focus on this. Okay. So just to review, you know that there's the neurotransmission occurs in the synapses of your axons. Okay, so your chemical neurotransmission in the brain includes processes of how chemicals are coded, decoded, transduced, and sent along the way. So, of course, to understand how the psychotropic agents or psychopharmacologic drugs function, it is essential to understand first the principles of these neurotransmission because, again, these medications primarily act on crucial molecules that play roles in this process. So these are the structures of the neurotransmitters, but I just would like you to be familiar with the common neurotransmitters that are affected by the psychotropic medications. And these are your noradrenaline, um, dopamine, serotonin, and your GABA, your acetylcholine, and your glutamate. Some of them, like your adrenaline and endorphins, can also be affected, but most of the psychotropic medications are centered on targeting these 6 neurotransmitters. So first, let's discuss about dopamine. So you know that dopamine is often referred to as the feel-good neurotransmitter because it's released when we experience pleasure or reward. So the function of dopamine is primarily on controlling mood and emotions, motor control, learning and memory processes, but it can also help in regulating attention and hormone production, and primarily implicated in the reward system. So just as a review, if you are familiar with this and you have discussed this in your neuroanatomy, there are dopaminergic pathways in the brain. So there are actually 4 primary uh, dopaminergic pathways in the brain. We have the mesocortical, we have the mesolimbic, nigrostriatal, and the tubero-infundibular. So for some, it's called tubero-hypophyseal dopaminergic pathway. So in mesocortical and mesolimbic, if you have remembered or you remembered your lecture in schizophrenia, mostly it has been discussed that when you have negative symptoms, the affected part or the pathway would be your mesocortical. It means that there is less dopamine areas in your or dysregulation in your dopamine area in your mesocortical. And in your mesolimbic area, you know that if you have more positive symptoms, then maybe your mesolimbic area is more affected because it can, in schizophrenia, it produces positive symptoms. So in nigrostriatal, this is very important as well when it comes to psychopharmacology because most of the medication, when they target, for example, dopamine receptor antagonists, they can target all of the pathways, right? So when you have an antagonism of your dopamine, so it inhibits the dopamine. So you can affect these pathways. And for example, in nigrostriatal, if you inhibit that, then it can produce side effects of the medication like extrapyramidal symptoms. So just as a review, mesocortical area, it comes from your ventrotegmental area to your prefrontal cortex. That's why when you are when you have a patient with schizophrenia, if the mesocortical area is affected, the executive functioning is affected in the patient. So for example, there are problems in working memory and attention because the mesocortical area's function is primarily centered on that. Okay, so if you give a dopamine antagonist, it can worsen the negative symptoms of your schizophrenia and even affect the working memory and attention of the patient. That's why it's very common among schizophrenics na nagtitake or who are taking antipsychotics that they complain with these cognitive deficits. Okay, so your mesolimbic area again in schizophrenia, it's usually associated with positive symptoms, but the structures involved here would come from your ventrotegmental area to your nucleus accumbens. So, and amygdala included. So what does this represent though? So the function of your mesolimbic area is centered around the representation of reward. So for example, your drugs of recreation that target dopamine can affect mesolimbic function. So that's why the addictive property of the drugs may target these particular structures. So it's also the major target of the antipsychotics. So that's why I want you to be familiar with that. Okay. Again, for the nigrostriatal area, if you want to learn more about it, it comes from your substantia nigra to your basal ganglia. That's why when you give an antipsychotic and it targets the nigrostriatal, you inhibit the dopamine, they have extrapyramidal symptoms. It's because the basal ganglia circuits are involved in motor planning and execution. That's why they can present like Parkinsonian symptoms. Remember, in Parkinson's disease, you have degeneration of your cells that produce your dopamine. So it can present as symptoms like that of Parkinson's when you give an antipsychotic. Okay. For the tuberoinfundibular area, it comes from your hypothalamus or your infundibular nucleus to the median eminence of your hypothalamus. So why is it important in our psychopharmacology? Because when you give medications that can decrease dopamine in this area, then you can present with gynecomastia and even galactorrhea in patients. So it's very common to have side effects like that. All right, so what about serotonin? So serotonin functions primarily in terms of regulating mood, anxiety, sleep, and appetite. Okay, so in frontal cortex, serotonin function in helping with concentration, ensuring that you have energy and interest in your usual activities, and even pleasure, and even regulate motor or psychomotor movements. Okay, it can also be present in your basal ganglia, and sometimes when you have this regulation of your serotonin, it can present with agitation and obsessions. And in your basal ganglia, there's also the function of your slow wave sleep. So sleep centers, when you have affectation of your serotonin, you can have difficulty in sleeping, and the affected sleep stage would be more of the slow waves or the earlier stages of the sleep, okay, rather than your REM sleep. Okay. For the limbic areas, it's primarily concentrated to regulate mood and anxiety, so that if you have this regulation of your serotonin, you can have depressive symptoms like your guilt, your suicidality, and worthlessness. Okay. For hypothalamus, serotonin can regulate the sleep and the appetite as well. So in this particular slide, just be familiar with the serotonin pathway because it's very important for you to remember or review the different structures of the different structures that are that contains the projections of your serotonin. Okay, so the cell bodies, for example, if your serotonergic neurons are located primarily in your raphe, midline raphe nucleus of the brainstem. So the rostral nuclei project to the basal ganglia, your thalamus, your hypothalamus, and the rest of your limbic system and cerebral cortex, while the caudal nuclei send projections to the brainstem and the spinal cord. And that's why the rostral nuclei will deal primarily, for example, with the appetite, regulation of appetite, the mood, while the rest, for example, your caudal nuclei, which send projections to your brainstem and spinal cord, will help regulate your movement and the sleep centers in the brainstem part of your uh, brain. So just be familiar as well with the different receptors of your serotonin. So you have your 5-HT receptors. So if you hear them with the rest of your lectures, just know that it refers to your serotonin receptors. So there are 7 known um, serotonin receptors so far. So from 5-HT1 to 7. But most of the receptors that are targeted by your psychopharmacologic agents targets your 5-HT1 to 2 receptors. So for example, in 5-HT1A receptor, so it's a G protein coupled receptor type. So it works via acetyl uh, AC activation. And the clinical implication of this would be it's targeted by agents that help in your anxiety and depression. Okay, so for example, if you have an antidepressant that target your 5-HT1A, then it can help alleviate your anxiety and depression, even migraine. Okay. For 5-HT2A to 2C receptor, so it's also a G protein coupled receptor. It's primarily targeted by antipsychotics, especially atypical antipsychotics. That's why it helps in the management of schizophrenia symptoms. So, and it can also have effects on alleviating depression when the pharmacological agent targets 5-HT2A and 2C as well. That's why in the clinics, if you're going to go into the clinics and you're familiar with the antipsychotics, some clinicians would use atypical antipsychotics as an adjunct to your antidepressants to target depression. Okay. What about norepinephrine? So if you're familiar with norepinephrine and epinephrine, they are adrenal hormones, right? So they're your stress hormones. So what are its function? So it regulates arousal state, the vigilance, and the stress response. Primarily, it deals with autonomic responses. So if you have increased norepinephrine levels, then of course your autonomic nervous system is more activated. It can help regulate your mood and, of course, facilitate alertness and wakefulness and even pain response. So just be familiar with the locus um, pathway. So you know that your norepinephrine is produced by your locus ceruleus, right? So it's in the dorsal pons, and it plays a major role again in the regulation of arousal state, vigilance, and stress response. So the firing rates of these neurons actually respond depending on the stimuli. So for example, if there are stressful stimuli, then it changes the firing rate. So it increases in firing rate, eventually leading to increased secretion of your norepinephrine. So aside from the locus ceruleus, the lateral tegmentum of the medulla and pons also contains neurons for secreting your norepinephrine. So it has a critical role in the autonomic and your endocrine functions. So what about GABA or gamma aminobutyric acid? So GABA is an amino acid with high concentrations in the brain and the spinal cord. So if you remember GABA, it acts as the major inhibitory neurotransmitter in your central nervous system. So again, since inhibitory neurotransmitter, then it's crucial for the inhibition of excitatory neurons. So GABA is helpful in facilitating sedation and sleep, motor control, anxiety regulation, and hormone regulation. And that's why if you have, for example, difficulty in sleeping, it means that medications that activate GABA more will help in alleviating sleep problems. What about glutamate? So in contrast to GABA, which is an inhibitory neurotransmitter, glutamate is an excitatory neurotransmitter in the CNS. So it's actually the most abundant excitatory neurotransmitter in the CNS. So its primary function is to activate the neurons. So glutamate has a lot of uses or functions. So it can help in the neurotransmission. It has studies that show that it's actually implicated in neuroprotection as well as brain development, even in adults. So acetylcholine is also a common neurotransmitter that is affected by psychotropic medications. So it plays a vital role in both the central and the peripheral nervous system because it helps in regulating autonomic responses forming and consolidating memories, arousal and REM sleep induction, and contribute to the control of posture and movement. And that's why when you have, for example, dementia or major neurocognitive disorder, when you have decreased acetylcholine activity, then you have difficulty in your memories, especially short-term memories. Okay, so in psychotropics or in psychopharmacology, for example, for those who have side effects or extrapyramidal side effects in antipsychotics, those that are um, anticholinergics, agents that are anticholinergics can help alleviate the side effects because remember, acetylcholine is also involved in the control of posture. Okay, so for histamine, just know that it modulates arousal and wakefulness. It also is involved in feeding behavior and neuroendocrine responsiveness. So why is it important for us to know this in psychopharmacology? Because most of the medication also have um, effects on the histamine receptors. So that's why most of the, for example, antipsychotics and even some antidepressants, when they target histamine, they can have sedating properties. So it's important to choose which one can help for those with difficulty in sleeping and which ones do not help with sleep. So that if a patient, for example, has hypersomnolence or increased sleeping, you do not give the medication that targets histamine. So just be familiar with this. You will review this along when you go into the different conditions, the management of the different conditions. So just remember again, the dopamine is primarily implicated in psychosis like schizophrenia, substance use disorder, and your ADHD or attention deficit hyperactivity disorder. Your serotonin is implicated in your depression or depressive disorders and anxiety disorders, while your norepinephrine is implicated in anxiety disorders, post-traumatic stress disorder or trauma-related disorder, and even bipolar disorder. For GABA, it's implicated in sleep disorders and anxiety disorders as well. And glutamate is also implicated in psychosis and depression, while acetylcholine, like what I mentioned, is implicated in dementia or neurocognitive disorders. Okay, so just to review the neurotransmission. So because we're going to go into the other mechanisms of action of the drugs. So you know that neurotransmitter molecules are, of course, synthesized from their precursor under the influence of enzymes. For example, the synthesizing enzymes. So if you have synthesis of your neurotransmitter, they become stored in your vesicles. So these vesicles are eventually transported near the synapse. Okay, so the transported vesicles fuse with the presynaptic membrane and release, of course, their neurotransmitter molecules into the synapse. So, and then these released neurotransmitter molecules eventually bind into your autoreceptors and inhibit subsequent neurotransmitter release so that you have feedback regulation of these neurotransmitter and it will not be excessive in nature. But most of the released neurotransmitter molecules will then bind to your postsynaptic receptors, and these binding to the postsynaptic receptor will, of course, facilitate the effect of the neurotransmitter. Okay, so if you do not need the neurotransmitter anymore, it can be deactivated either by reuptake, so that you can use again the precursors, or by enzymatic degradation. So I just want you to be familiar with this because we will discuss it briefly later. Okay, so these are just receptor interactions. I just want you to be familiar or review this. So you know that your agonist, if you have a substance or a neurotransmitter that works as an agonist, then it can cause full activation. Okay, so for example, if a medication which has a similar effect to a substance who is an agonist, if you give, for example, a dopamine agonist, then it means that the activity of your dopamine increases fully. Okay, if you have an antagonist, from the name itself, the molecule or the drug binds to the receptor, then it will not inhibit any process, but it will not also produce any activation. Okay, so if you have both an agonist and an antagonist, then of course the effect would be less activation of the neurotransmission. So just as a maybe an easier thing to understand, no easier slide to understand. If you um, deal with the word antagonist, then it means that it binds with the receptor but does not produce any effect. But because it's still it's still bound with the receptor, even if it does not produce any effect, there is no activation that happens. Okay. The inverse agonist, on the other hand, is different from your antagonist because it binds with receptor and inhibits its intrinsic activity. So it means that um, the intrinsic activity itself is inhibited and there is no activation that happens again. Okay? But it's different because in antagonist, again, it does not produce any effect. Okay? For agonist, it binds with the receptor and activates it fully. And we have what we call partial agonist, which binds with the receptor and activates it partially. So example of partial agonists that you might encounter in psychiatry would be your aripiprazole and your brexpiprazole. So it has its own benefits if you give a partial agonist. So these are the common mechanisms of action of your psychotropic medication. So for example, you can have molecules or drugs that cause interaction with your receptors. For example, a dopamine antagonist, a serotonin antagonist, a GABA agonist, for example. So example of a dopamine antagonist would be your antipsychotics. So specifically your typical antipsychotics or your first generation antipsychotics. So if it's a serotonin dopamine antagonist, again, it's an atypical antipsychotics because it's a newer medication. Okay. So another mechanism of action of your psychotropic medication, if it affects the reuptake of your neurotransmitter. So for Sorry, I got disconnected. Can you see the screen?
Yes, po, Doc.
Hello?
Yes po, Doc. We can see the screen po.
Hello, can you see it now? Okay, so I stopped, I think, at benzodiazepines. So again, in benzodiazepines, it activates GABA receptors, causing inhibition. So it works primarily in your receptor interaction as well. While your monoamine oxidase inhibitors, so it inhibits enzymes that degrades norepinephrine and your serotonin. So it works. This is one of the example of medications that works or targets the enzyme degradation pathway of your neurotransmitters. Okay, so again, the neurotransmission is the basic mechanism of action of your psychotropic medications mostly. But of course, there are other processes that facilitates the effects of these medications. For example, there are medications that can activate G protein coupled receptors aside from the ones targeted by your neurotransmitters, as well as can affect your gene expression directly. Okay. So last topic to discuss will be the considerations, including the patient factors, the dosing duration, and the monitoring of your medications and your ethical considerations. So first is patient-related factors. So it influences the patient's response to medications and sensitivity to side effects. So in psychopharmacology or in the management in psychiatry, there is no one-size-fits-all approach to the pharmacological treatment. So you have to really consider the patient-related factors. So let's start maybe to just introduce to you how patient factors can be considered in the management of a case. So this is a case of patient X, 30-year-old female, housewife with two children, an accounting graduate, but decided to be a housewife when she married. She's a Roman Catholic, right-handed, and a child. So the history of present illness started 6 months prior when she learned that her husband has been unfaithful to her. So she developed depressive symptoms of depressed mood, poor appetite, lack of interest in all her activities, didn't want to take care of herself, with increased sleeping hours, does not want to take care of her children as well, and just sleeps all day. So she had feelings of guilt over not being good enough as a wife, with thoughts of wanting to disappear. Medical and psychiatric history revealed previous depressive symptoms after giving birth to her first child, but no consultation was done. She's a known case of heart disease, um, maintained on unrecalled medications. It got off. For family history, her mother is a diagnosed case of bipolar disorder, while father is diagnosed to have anxiety disorder. Substance use history revealed no history of illicit drug use. She's also non-smoker and non-alcoholic beverage drinker, but she admitted drinking 5 to 6 cups of coffee per day. So upon consulting a physician, she was diagnosed with major depressive disorder and was started on an antidepressant, particularly sertraline, at 50 milligram per day. So her symptoms improved after 4 weeks of taking medication, and she was advised to continue them. However, after 8 weeks of taking it, she was noted to be easily irritated and would be inappropriately happy with hypertalkativity and would frequently buy unnecessary things, causing her to have massive debts. She had poor sleep, but she claims that it's enough and she can still take care of her children and wants to apply for a lot of part-time jobs to support the family. So looking at this case, then we go now to the patient-related factors. So before we discuss how to apply them, the patient-related factors can include, of course, your diagnosis, whether you're accurate in your working impression, the concurrent medical condition and other comorbidities, the past treatment response of the patient, if she or he has been treated before, and the response of family members to the medication if they have been diagnosed as well with psychiatric conditions. So first is diagnosis. Of course, if you cannot correctly diagnose a disorder, it will diminish the likelihood of your optimal drug selections. For example, if you're just treating the anxiety disorder, but clearly the patient has depressive symptoms, then only the symptoms will be addressed and you will fail to address the rest of the problems of the patient. So treatment failure or exacerbation of symptoms should prompt reassessment of the working diagnosis. So sometimes in psychiatry, the diagnosis can change. Okay, so because we look at the long-term manifestation of the disorder and we try to tailor the treatment according to our impression. Okay. So for example, in patient X, you know that the patient was diagnosed with major depressive disorder because of the depressive symptoms. But eventually, the patient developed symptoms that may mimic or may imply that the patient has um, uh, not depressive symptoms alone, but has um, hypomania or mania symptoms. Okay. So again, take note that X has a family history of bipolar disorder. So in this case, if the patient has a family history of bipolar disorder, do not forget to rule out bipolarity in this patient. Why? What is the implication of this in selecting a medication for this case? If you know that the patient may have a bipolar disorder rather than just a unipolar depressive disorder like major depressive disorder, then giving the patient sertraline or an antidepressant might even be a problem in the treatment in this patient's case because it can actually push the patient into mania, which might have been the case in patient X. Okay. So for past treatment response, of course, you uh, do a very good history of the patient's psychiatric history and response to medication. Also check the family of the drug response. So for example, even if it's not the same medication, exactly the same medication, then you can check whether uh, medications under that class of medication can work for the patient. Okay. If a drug has previously been effective in treating the patient, you can use actually the same drug. Except, for example, if the patient had concerns over the previous medication, like for example, side effects, not very convenient for them to take it, Okay, so for the response in family members, on the other hand, you might consider this. For example, if the patient is a treatment naive, or he or she doesn't have any history of medications, so you can consider uh, using the same medication that has worked for a family member if that family member has a similar diagnosis. Because studies have shown that drug responses cluster in families, and that history of positive response to treatment with a drug should be considered in making a decision, particularly in family members with similar or related diagnoses. Okay. So for example, in patient X, based on this factor, what additional information should you ask for the patient or family? Of course, have to ask if the patient has had medications before, or if family members, particularly in this case, you have a mother with bipolar disorder, um, what you have to ask what worked for the mother, and you might want to consider that in treating the patient. If the patient developed anxiety symptoms as well, then the patient's father has a history of anxiety disorder, right? So you might want to elicit what kind of medications work for the patient's father, and you might consider it in treating the patient as well. Okay, other patient-related factors include your concurrent medical or psychiatric disorders. So, of course, medical conditions may present with psychiatric symptoms, like, for example, thyroid disorders. Hypothyroidism can mimic depressive symptoms. So, medication that has the least risk of exacerbating any pre-existing medical problems should be selected. So, pay attention to drug-drug interactions if the patient is maintained on any medications that are not psychotropic agent. Okay. Consider as well illicit drug use, caffeine, nicotine, and alcohol intake, because these can affect your response to treatment or the patient's response to treatment. So, for example, in nicotine, it can affect the levels of the drugs or the psychotropic drugs in the patient. Okay, so caffeine can also exacerbate symptoms in the patient. For example, anxiety symptoms. So in patients X, again, caffeine can aggravate some symptoms. So for example, if the patient will develop difficulty of sleeping, you might be confused whether it's because of the caffeine effect or it's because of the um, mood dysfunction in this patient. Okay. Check if medications also has cardiac side effects. So choosing the medication for patient X because she has a known cardiac disease, of course, you have to take into consideration which one has the least risk of developing cardiac side effects. Right, so side effects, since we mentioned that, results from the pharmacologic action or property of the drug and the patient's susceptibility and sensitivity to the drug's actions. So it's actually unavoidable in terms of risk. Okay, all medications has potential for side effects, but you should just be familiar with the more common adverse effects, of course, as well as those with serious consequences. So if the patient has a medical condition or a prior reaction that increases the risk for a certain side effect, of course, you do not choose any similar compound that cause that reaction. Okay, so choose another compound maybe that may have the least risk to induce a similar reaction. So in side effects, for example, if a medication if is an antipsychotic and you give it to a patient, it can induce the side effect via its same pharmacological action. So, for example, antipsychotics can block your dopamine receptors, D2 receptors in your nigrostriatal pathway, because we can't avoid it. It's a pharmacological action. Then your patient can develop extrapyramidal symptoms. Okay. But some medications can induce side effects via unrelated properties. For example, for atypical antipsychotics, it has additional effect on your histamine receptors, which can cause weight gain. Okay. Time course also affects the sensitivity of the patient to adverse effects. So the adverse effects may differ in terms of onset and duration. So for example, an SSRI or SNRI, like your venlafaxine, it's common for the patient to experience nausea, gastric symptoms, and weight loss during the early treatment phase. Okay, but it abates as the patient takes it later on. So it's very important for you to psychoeducate so that they expect that it's only temporary and that it will resolve through time. Okay. But for some, it can be late appearing. For example, weight gain. So SSRIs initially can cause weight loss, but when they take it repeatedly and for a longer period of time, then it can already induce weight gain. Okay. But other side effects of SSRI can be persistent. For example, dry mouth, it can start as early as the first week of treatment until or continuously until the patient discontinue the medication. Okay. Another example of how time course affects the side effects of the medication is your antipsychotics, particularly your first generation antipsychotic like your haloperidol. So in first generation antipsychotic, you can experience extrapyramidal symptoms throughout the course, but if you take it in the long term, eventually at later stage, you may develop tardive dyskinesia, and this is one of the most uh, dysfunctioning side effect of your antipsychotic because tardive dyskinesia, unfortunately, is very difficult to treat. So sometimes you can't even treat it anymore. So it becomes permanent for the patient. Okay. So what is this, what are the impact of the side effects? Of course, decreased compliance with the treatment, but overall, the risk of life-threatening side effects with psychotropics is low. But of course, you still need constant monitoring. So dosing duration and monitoring should also be considered in your choosing or choice of medication. So these are the factors affecting clinically effective dose or the characteristics of the drug, patient factors such as sensitivity and ability to metabolize the drug. So if there's low metabolizers, of course, you don't give higher doses of the medication. If they're rapid metabolizers, then you may give a little bit higher dose of the medication. Just be careful and monitor concurrently. Medical disorders, you have to pay attention to that. And of course, the medications taken by the patient and history of exposure to previous medications. You should use effective doses for sufficient periods and avoid subtherapeutic and incomplete therapeutic trials. Okay. So it's the time of dosing is usually based on the plasma half-life. So just be familiar with the half-life of the medication and of course the side effect profile. Be careful of overdosing. So when we choose psychotropic medications, since we know that the patients, especially those with depression, mood disorders, and psychosis are at risk for suicide, then you have to particularly pay attention to the safety in overdosing. But almost all of the newer agents have a wide margin of safety when taken in dose. So what we do when we assess the patient to have high suicide risk, we prescribe just enough number of tablets. We do random pill counts. We ask the family members as well to supervise the dispensing of the medications. Route of administration, you consider convenience and the compliance of the patient, and of course, the pharmacokinetics and pharmacodynamics of the medication. So, for example, for those who do not have any difficulty in taking tablets or oral preparations, then you can use the enteral preparations. Or dispersible tablets are very convenient for some who want to have the fast effect of the medication because it's usually put in the mouth and it dissolves in the mouth immediately. So medyo faster yung onset of action. Okay, so you might encounter this in the ER. For parenteral, for example, short and long-acting injectables. For short-acting injectables like your haloperidol, you can give it via IM if, for example, the patient is agitated and it works faster. For long-acting, these are the medications that you give, for example, every 3 weeks, 3 to 4 weeks. It's very convenient for patients who do not want to take medications every day. Okay. Other routes include intranasal, for example, intranasal antidepressants. It's faster in action and the absorption is higher compared to your oral. Okay. Duration of treatment, most have high rates of chronicity and relapse. Of course, long-term treatment is often needed to prevent recurrence. So consider the symptom duration, the family history, and the patient's tolerance of and benefit from the medication. So usually the phase of treatment is divided into three: the initial trial, the continuation phase, and the maintenance phase. So the initial trial, usually it lasts several weeks because of the delayed therapeutic effects of the medication. While in your continuous phase, this is usually the clinical and statistically significant protective effects of your medication. While in your maintenance phase, it depends on several factors. For example, the patient has had a number of relapses, and the chronic nature of the illness should be considered. So some medication or some disorders doesn't need to have the maintenance phase, but most of the disorders in psychiatry are treated long term. Okay. So for monitoring, of course, it's based on clinical circumstances and the drugs used. So in laboratory workup, you establish the baseline values and rule out underlying medical problems. Then you monitor side effects accordingly. So more often than not, we don't do frequent monitoring of the laboratory workup unless it's really needed. Okay. So monitoring of drugs with narrow therapeutic indexes, for example, your lithium carbonate is very important. So we do assays, for example, of drugs. So when it comes to the side effects, you can, for some, for example, for those medications that have propensity to develop metabolic syndrome, you just do it regularly, but not naman so frequent that the patient will be burdened with the financial costs of the labs. Treatment outcome, of course, is to eliminate all manifestations of a disorder and help them to regain the ability to function well and to enjoy life as fully as before he or she became ill. So our target is remission, meaning return of functionality of the patient to their baseline functioning. Okay. But some will just have response to the medication. And when we say response, it's just a 50% decrease from the baseline score of a standard scales. For example, if the patient is treated with antidepressants to target depression, we use standard scales to determine the baseline score of the patient. And then if the patient has decreased up to 50% of the score, then it means that the patient responded to the medication. But if the patient had full return of functionality and further decrease of baseline score, then meaning the patient is already in remission. Okay. So lastly, informed consent and patient education. So of course, trust in providing medication is important in terms of compliance. So psychoeducation is very important, including treatment choices and side effects. But we usually honor the patient's preferences unless, of course, the treatment that we recommend offers a clear benefit in terms of effectiveness, tolerability, or safety. So we also pay attention to the emotional and psychological significance of medication for the patient and their family. For example, pay attention as well to the environmental factors and psychosocial stressors, available support systems. Um, some patients would see the treatment as something that can help them, and some would see it as a burden. So you have to try to see the psychodynamic factors there. Okay. So that's it. So just to leave you a quote. So drugs are not always necessary, but belief in recovery always is. So these are the references that you may want to consider reading. And if you have any questions, I am okay to answer them. Thank you for your kind attention. Any questions ba? You can also send me a message in Canvas if you have any questions about the lecture. Okay. Questions? If none, thank you for your attention and have a great day.